Well, thank you again for having me. Um, I do want to preface and kind of give you a little bit of background of where I kind of came into this and kind of where I have kind of based some of this topic and talking about the intricacies of intimacy and aging from. So when I started with the Area Agency on Aging, I started as an ombudsman, which is a resident advocate. I was in a lot of the assisted living, skilled nursing homes, and was asked a lot about, well, what happens if you encounter residents that are together? You know, as a brand new ombudsman, I wasn't sure. Um, and so I started kind of researching and doing a lot of um, asking a lot of questions of what is normal, what is not, how do we approach this topic, and kind of over time have put together and gathered quite a bit of information on this touchy and maybe taboo subject. So I'm actually going to share my screen. Um, so I usually I try to put some humor into this subject because I think it sometimes it can be a little it can cause the giggles, and that's okay. So really what I want to challenge and share this morning is to challenge some of those stereotypes around aging, intimacy, and sexuality. What that means beyond physical attraction, um, how desire can evolve over time, and then how individuals, especially with some cognitive changes like Alzheimer's and dementia, how they can still experience that deep connection. And so hopefully I can give maybe some practical ways as caregivers and professionals that we can learn to approach these topics with empathy and respect. So again, some of just the objectives. What's the difference between sexuality and intimacy? When I was in facilities, that tended to be, those were interchangeable terms, and there is a little bit of a difference there. I want to debunk some of those common myths about sexual desire and aging, explore a little bit about how dementia affects intimacy in our relationships, and then give a couple of strategies for caregivers and us as professionals to support those healthy connections. I should also preface, like, I am not a sex therapist. I do hold a master's degree in health promotion and programming, but there's a lot of different intricacies around this topic. So I also just want to say at the beginning, like I'm not a sex therapist, just somebody who ended up talking a lot about sex as a default. So sexuality, it's more than that physical attraction. It's that capacity to experience or show sexual feelings. It can also be used to define a person's sexual orientation. Sexuality is diverse. It can change over time. In some of my research, especially around that topic of dementia and cognitive change, um, a couple of articles, Stewart and Sundy, I liked this quote a lot, that it's an integral part of the whole human person. And it can largely determine who we are. And it's just one factor of the uniqueness of every person. So, that physical attraction, and maybe how you identify, whether you identify as straight or gay, however that might be, that can all be under that sexuality umbrella. Whereas intimacy, the American Psychological Association defines intimacy as that interpersonal state of extreme emotional closeness, that each party's personal space can be entered by any of the other parties without causing discomfort. So, especially in those facility settings or in your home, intimacy can just be closeness. It can be familiarity. It can be a hug. It can be sitting close on a couch, holding hands. It can also include sexual activity, but that doesn't mean, just because you're intimate does not mean that there's sexual intercourse happening, right? We can have intimate relationships with a close friend. So that was a lot of that re-education for facility staff of, well, they were close. Okay, what does that mean? They were sitting next to each other on the couch? Well, yes, it didn't seem appropriate. Well, where are they? Do they have dementia? What's going on there? Let's look at that bigger picture. So just as we age, there's a lot of changes that happen, right? I think we can all agree we've maybe experienced some of those aches and pains that accompany just the normal aging process. Things don't quite go back to where they used to be. Um, our vision changes, our hearing might change. So there's a lot of physical changes that can happen. Our hormone levels change. We might gain weight, we might lose muscle tone, our appearance can change, and that could be difficult for some, especially with that sexual, like physical attraction, or maybe we're not as comfortable in our bodies. And so that might look different in how we experience that physical intimacy. There also might be some just health related changes. We might have more chronic conditions that have different consequences, diabetes, heart disease that might cause issues if you wanted to engage in sexual activity. There might be impotence. There might be other issues that are happening, especially as we age, right? And so with those physical and health related changes, there can just be some changes of expression in what physical intimacy could look like, and just intimacy in general. And things change, we evolve over time. So again, some of those causes of sexual challenges, physical factors like arthritis, chronic pain, heart disease. There might have been a stroke. You might have recently had surgery, and if you're in a cast, physical intimacy might be a little more difficult. So what does that then look like if you still desire intimacy with your partner? Depression, anxiety, those psychological factors that might change things as well. And then just some of those lifestyle factors too. And some medications like antidepressants can cause some issues with sexual function. Alcohol use also can do that. If you're having incontinence issues, that might be embarrassing, and so you might not want to engage with your partner. So things that we think about. Some of these are just parts of aging. Some of them happen to everybody across the lifespan, but these can all cause some challenges when we're wanting to engage with our partners. So there's some myths around just sex and aging, and I think this is partly why it can be a taboo subject, especially when we think of, older individuals engaging in any type of intimacy. Media does not portray anybody aging as sexually active. Sex is for the young, it's for the attractive. You're not seeing a lot of that in normal media today. I think there's some challenges to that now. There's a couple of new shows that are more geared towards aging, but the truth is desire and intimacy exists at every age. It doesn't mean that it's only the young can, have sex or enjoy that. We don't age out of being sexual. It might change. It might look different. A lot of adults remain sexually active and interested later in life. So something to kind of to keep in mind. Another myth is it's dangerous for older people. You might, fall and break a hip, or something might happen, and that could happen, right? But if we're careful, we're consulting our doctors, if we're being open and honest and vulnerable, and expressing those things. That this is what I want. Um, how can, with my medical issues, how can I make that happen? You know, there there are things that we can do. If there's some sexual dysfunction in both men and women, there are medications that we can take. There are things that we can do to make that intimacy, physical intimacy, possible. Um, Again, with that myth of those physical changes, like after menopause, no women are having physical intimacy, or erectile dysfunction means never again. And again, there's medications and there's some lifestyle changes and maybe some adaptations to intimacy that you can then form some different types of connection. And then the last kind of issue is only young adults need to worry about STIs, and that is far from the truth. In fact, largest the biggest number of people that are being diagnosed with sexually transmitted infections are the aging population, partly because after menopause, and there isn't that fear of pregnancy, and so using protection and safe sex practices kind of tend to go out the window. Um, and that education around STIs really isn't there. And so teaching people about safe sex practices is really important, because we want to decrease the instance of STIs in our older populations. And just, thinking about intimacy, it can include a lot of different activities: emotional closeness, physical closeness, for older adults. Let's see. Um, all right. But what happens when our partner is diagnosed with dementia? That dementia can impact our sexual function and intimacy, and it changes that dynamic within your partner, and within that partnership. Dementia can change a person's emotional and physical capacity for affection. When a person's living with dementia, their sexual behavior, needs, and desires, those can also change, and the partners can change as well. I also want to mention frontal temporal dementia can affect a person's inhibitions, specifically around sexual behavior and their attitude towards sex. A lot of times those inhibitions are gone. So just think of no filter at all. So what might happen is a person with frontal temporal dementia says exactly what they want, or might inappropriately grab you when they might not have done that before their dementia diagnosis. They might not be able to feel empathy and quite understand, like, why that's not okay, and why, grabbing grabbing me is not an appropriate thing in public, or without consent, right? So something to also keep in mind as we're caregiving for people that might have dementia, that especially frontal temporal dementia, if you're seeing those decreased inhibitions and just a lot of more odd behavior that maybe previously you wouldn't see, that could be a reason. Um, but really, what happens is it just reshapes how we might experience affection, desire in those relationships. Um, a lot of times, maybe they'll want to just be able to hold something, and so having an animal, or even you might see in a facility setting holding like a doll to kind of be in place of somebody, like that closeness that can be beneficial. Again, with dementia, the desire may increase, um, but there might also be some physical symptoms that could cause some significant changes to the way that they're able to experience physical intimacy. So there might be some behaviors, some misplaced affection. What we might see in someone with dementia is, and again, this is coming from kind of more that facility assisted living memory care side. Maybe they are married, right? Um, but in the facility, they're engaging with another adult. It's not their spouse, but in their mind, that is their spouse, right? And so that misplaced affection is common. They're seeking some sort of intimacy, just being close to somebody that they think is their spouse. Um, and then there's always those communication barriers as well. There might be some, difficulty expressing their needs, or as the caretaker or the partner to the person with dementia, a difficulty in interpreting those cues or those requests. Like I'm not quite understanding what you're asking for. Um, to go back a little bit, that hypersexuality is, occurs often with people with frontal temporal dementia, but anybody with dementia also might exhibit an increased sexual interest or inappropriate behaviors. Again, that misplaced affection, maybe masturbation in public, like, oh my gosh, that would have never have happened. You as the caretaker are maybe mortified, and to redirect that person to a private space, like, that's fine, but let's do that in a private location, um, to preserve their dignity, but also that's their desire for some sort of physical intimacy. And again, those cognitive impairments, somebody with dementia might misinterpret cues, or they might initiate sexual activity without consent. And so, um, as we care for people with dementia, and we're helping those caregivers to just be aware that those things might happen, and how to support and and kind of give name to these behaviors. A question that I often got asked, in facility settings a lot was, well, what's the risk to that individual? Um, if you have dementia, your cognitive function is has changed. So are you capable of making those decisions? Are you able, as the person with dementia, to recognize with whom you're having that relationship? Do you know that that is your spouse, or is this another person in the facility next to you? Or and you are walking around thinking that that is your spouse. Are you able to communicate verbally, or are you nonverbal? Um, do you understand what it means to be physically intimate? Are those behaviors keeping with your past values, beliefs, and religious views? I mean, that was probably one of the biggest issues that we would run into in facilities. Hearing their children, well, my mother would never have done that. My father would never have talked to anybody in that way. And that is probably very true. But with dementia, that person that you are seeing physically in front of you, their brains have changed. And while maybe in the past, um, holding hands with somebody that wasn't their partner or their spouse was out of question, but now they're changed. And so we want to look at the overall impact of that relationship in a facility, or that relationship in your home. Um, is there a benefit? So there's a home that it's an assisted living in New York. It's the Hebrew Home for the Aged. They started, gosh, in the late, maybe early 90s, which in my brain isn't really that long ago. And then you do the math, and you're like, that was like, that's 30 plus years ago. They started talking about this subject, about they had specific floors of their nursing home that were dementia only. And they started asking those questions of, well, is this okay? Can our residents here, can they engage in intimate relationships? What does that look like? And how do we support them? So what they ended up really doing is kind of defining some standards that they used to evaluate, is this a benefit, or is there um, is it causing harm? And so they'd have an interdisciplinary team that would really kind of observe, interview, and bring in the family, and try to keep those residents' autonomy and decision making as much for themselves as possible. And a lot of times, what they found was there was a benefit to those residents having somebody in that facility to hold hands with, or to sit close to on the couch with, maybe even um, lay next to each other in bed. And that, for them, that was intimacy, that was being close. Sometimes what we see as caregivers or in facility settings, um, as a widow or a widower, maybe you were married for 40, 50, 60 years. And so going to bed with someone every night was normal. And so now that change, or when you have dementia and your spouse is not in the facility, you're sleeping alone, and that's not normal. And so that's that's what you're seeking, right? You're seeking what you remember. And so, we want to know, is having somebody close, or is having some sort of touch, is that going to be a benefit to you? Would you benefit from something like massage therapy or pet therapy, or having, um, there are, the cat's the best one. The animatronic animals, the dog is subpar, but the cat actually meows and is pretty soft. But is holding that, is that going to be a benefit? And sometimes it also means, if you, as the caregiver, or the professional staff in a facility, if you see residents engaging in some sort of sexual and physical intimacy, it might mean just letting them be, shutting the door, and going about your business. It also means we have to leave our own bias at the door of what we think is appropriate, what we think, our maybe our religious values have formed. I understand, like, it's hard, right? But we also, they're adults, and as long as there isn't harm, um, that intimacy can be really beneficial for, not for everyone, and maybe, specifically for somebody that has dementia. So how do we support our caregivers, or support the people that we're out in the community talking to? Well, part of that is just recognizing that we all are human first. And so being human means that we all have sexual desire. We have human needs, and that doesn't stop as we age. It doesn't stop with disease processes like dementia. But we still need to assess that capacity to consent, and we want to maintain people's dignity and privacy whenever possible. We might need to identify some barriers or some unmet needs. Loneliness. We know loneliness and isolation increases risk for a lot of actual chronic physical conditions. Loneliness and isolation can lead to things like an increased incidence of heart disease, of dementia. When you're not engaging with people, you're not talking to people, some of those skills, when they're not used, we do tend to lose them. Being alone might make you anxious. If you, again, have been married and together with somebody for a long time, and now all of a sudden you're not, and you hear those creaks and, groans of your house, that can be a scary place for somebody. No matter your age. There might also just be some underlying behaviors of underlying medical conditions that um, could be a barrier. Um, if you do encounter something that might be taboo, it might be not what you expected, we want to respond calmly, not this big reaction. I think the same can be said if you have teenagers at home too, right? Um, Not to be like, gosh, because that can be scary, especially if you do have dementia. It can be really startling to be kind of met with that kind of abrupt, like, you know, reaction. And maybe we're going to need to use some redirection. We specifically would train for facility staff if you were to encounter somebody, you know, masturbating in a public space. Be like, well, you are allowed to do that, but let's take you back to your room so you can have some privacy, because that is something that we do um, in a private location. And just redirecting, not a reaction, not a judgment, just say, let's go to a different place. And it might also involve setting some boundaries. If you are caregiving for somebody with dementia and they're being maybe a little inappropriate or out of the norm for what you are accustomed to in your relationship, um, it might mean setting some firm boundaries. This is what intimacy will look like. This is what I'm okay with, and this is what I am not okay with. When that happens, I'm going to stop you, and we're going to change locations, change activities. We're going to redirect. Um, it might also be helpful to have one start having open communication now. With your partners, with your family, with what I would want to have happen. What we encountered a lot again in facilities was, well, my mom is married and she would have never wanted that. Again, your mom now has dementia, and so things are a little different. You know, we don't know what they might have said. Like, mom, what would you want if you have dementia and you are in a facility? You're still married to dad, but you're holding hands with Bob in the at lunch. Would you want us to stop that? And having those conversations sooner rather than later. It might be really awkward and uncomfortable. The same goes for having a living will ready, having your wishes and desires for in that event that you might be incapacitated, what that might look like. But having those conversations now, kind of like what Holly said, really saves a lot of heartache in the future. Um, and if you are in a facility or you're out and talking with people in facilities, creating those safe environments, creating some policies and procedures around what intimacy in your facility can look like. I know it can be really difficult, especially around consent and capacity and what is okay. But again, I think using some of the resources that are out there, and I have an entire page of just resources that people will have access to read, um, will be helpful. Also, as caregivers, we might need some extra support. We might need some counseling. Because going from a spouse to a caregiver is an abrupt change in role, and it changes the way that intimacy is expressed. Caregiving's a job. Being a spouse, that's a relationship. And so when that switch happens, there's a lot of change. And so supporting those caregivers in whatever way possible, knowing that they're not alone, making sure that they have access to resources and respite, just why the community care program with our agency exists, why there's programs like at Cathedral of the Rockies here in Boise to help give people respite as a caregiver so that being with their partner is not a job, but that relationship so that we can give that back to them. Um, let's, I will go to the resource page. So all of these are links to a lot of different resources that I have used and have found really helpful. I think probably one of the best resources that I found was that this is the last one on their slides, the last taboo. It is a dementia and intimacy guide from, gosh, well, I can just pull it up, um, from the UK. So where people tend to be less shy about talking about intimacy and sex, and we don't. This is what it is. But I think that this guide is really beneficial. Um, a lot of good content, but also a lot of scenarios that we might encounter and kind of ways that they worked around those, both in a facility setting and maybe at home. So I would highly recommend kind of reading through that one. I pulled a lot of information just from scholarly articles from oh the Academy of Psychology, a lot of resources also from the Alzheimer's Association. So there are a lot of other places to kind of continue this conversation. But I think the best the best thing to do is to have that conversation, to talk about intimacy and aging and our desires and what we would want to happen in case of being incapacitated and unable to make decisions for ourselves, and not making this that taboo subject, and instead talking and using this time that we have to discuss what our desires look like. And just knowing we're kind of getting close to time. If you do have any additional questions, and please feel free to contact me. Again, I'm not a sex therapist, I'm not an expert. I just really value the dignity of an aging person and that there are that ability to make their own decisions, and to experience the full spectrum of intimacy in their lives. You can always contact our office too if you have any questions on just aging resources in the area. You can use that number to contact the community care program.